Thanks for your kind words, and thanks Gaur, and thanks Nagi for doing the initial slog overs for me. I just got stuck up. The enthusiasm with which Gaur does it is addicting. I bring greetings from ILBS, and I'll briefly touch few topics, parts of it, before I go to the main policy. The global prevalence is 1 in 4, in diabetics 1 in 2, in obese almost all. Please remember these. In Asia 1 in probably 3, and India maybe 1 in 4. And this slide tells you that this is the century NAFLD will drive. And liver cancer, this data shows in maroon, is that 35 to 40% of all cancers are due to NAFLD, and India, like some other countries. So 40%, and that's what we also found, that 35% of all HCCs are diabetics. This is the data just published of about 2,600 liver cancers. And in this you will see that diabetes is 40% and NAFLD 35%. So it's a problem. And I want you to pay attention to these few slides, because that makes these slides were used for policy decisions. So if you have more than 10% fat in the liver, you have steatosis. These ballooned liver cells will not allow insulin to come inside. If insulin doesn't come, more and more insulin is produced, and therefore, very crudely, diabetes can develop. And therefore, we believe, like many others, diabetes is a liver disease. And then the journey you know very well. I won't take time. But what is important is, if you go and get your blood test, or somebody else gets it, is a high cholesterol or triglyceride, you just take a pill, not realizing from where has it come, and that's fatty liver. So all dyslipidemics have fatty liver. Then this goes and deposits atherosclerosis, heart disease, stroke, gallbladder stone. So they all are a result of inflammatory, or what I call as surplus nutrition inflamed hepatometabolic syndrome. This is an old slide just to tell you that high ALT, let's say it is 80, will mean that the intrahepatic triglyceride levels are very high. This study, old, but tells you if you take NAFLD and 14-year follow-up, almost 4 out of 5 NAFLD may develop IGT or type 2 diabetes, and the incidence, the risk is high, but regression reverses. This is the Framingham study. High ALT in young children below 20, the diabetes risk is 5 to 20 times. And ALT correlates not only with fatty liver, dyslipidemia, diabetes or its risk, or hypertension or heart disease and risk, but also all cancers, liver, breast, prostate. And this is based on another study from Korea, where an ALT of 20 was considered as normal. Anything above 20, the risk increases for all cause or liver related. And what we considered in India as 40 as normal, all cause mortality and liver mortalities increase in a 10-year follow-up. I'll briefly rush through increased risk of CKD in those who have NAFLD, increased risk of myocardial infarction and stroke in NAFLD, first cardio event and death in COPD in NAFLD with fibrosis, NAFLD and cancers, the thyroid cancer, you can see the risk increases, lung cancer, stomach cancer. So the central thought is liver fat precedes flames, and therefore diabetes, hypertension, CAD, or NCDs, but the core, and all of you would agree, is liver fat. So To reduce diabetes, stroke or heart or kidney disease, we need to reduce fat in the liver. And I have forgotten to stress upon PCOS or maybe sleep apnea and other similar problems. This is just a brief data of ILBS of about 4,000 NAFLD patients. Of the 4,000, you would see that about 50% of them have either diabetes or hypertension or obesity. So NAFLD has a second phase. Now what is the magnitude in India with 1376,816 above 18 years? With 30% estimate, you have about 244 million. That is 25 करोड़ लोग NAFLD से projected हैं. So we need policy initiatives urgently. Now this was the policy initiative which was led by Jeff Lazarus, and I like these slides very much. Something I'm doing or? I know that NAFLD should make noise, but all right. So please pay attention to this. Policy initiatives at leadership. We were lucky. Human and economic burden, we don't know. Awareness is 1%. 99 out of 100 physicians say, क्या है यार, fatty liver तो मेरे भी है. Treatment and care, nothing. Policy strategies and whole of society approach, missing. Patient and community perspectives, lacking. And defining and implementing models of care, totally lacking. And I want you to read this beautiful paper. I must have read it half a dozen times. Let's say leadership role, and we are lucky that Dr. Duseja and Dr. Sanyal and many others are here. The national and regional liver associations in collaboration with government and stakeholders. That's the leadership requirement. Do you agree with this? We need leadership, societies and others. What is the national status? There are taxes on sugars, but there is no school-based environmental cultural intervention. Our schools have no initiative, and obesity in the kids is close to 20%. There are no national guidelines on physical activity. There is no incentive for workplace and healthy lifestyle. If you look at Australia and New Zealand, almost everything is yes, and they are very healthy, quite unlike India. So we need, and I am working on all these initiatives at a separate level. Now, as Dr. Narendran said, integration of NAFLD into the national program for cancer, diabetes, stroke and cardiovascular disease. So this was a groundbreaking initiative on February 21, just about 2 years ago. And as it was covered in JHEP, that out of 100 marks and 102 countries, in the preparedness for fatty liver, India scored 42.7. Much less. Still it fails. It doesn't mean कि यार 42% हैं तो pass हो गए. No. But yes, amongst 32 countries who got 0, India did better. Now, please pay attention how each one of you, each one can help. First is health promotion, awareness generation and promotion of healthy lifestyle. I am not going into details of this. For a whole of society approach, whole of society needs to understand fatty liver disease. What is whole of society? I myself, I don't have to go to a doctor. If I have fever, I know I have fever. So self-testing, screening, everything is self. And early detection. All this is done by the person himself. Point of care is not required. You are the point of care. Let's see how we achieve it. Then point of care diagnosis to confirm, stratification, referral. access to affordable treatment and rehabilitation. Now this is what we covered and was based on the Lancet paper. I would like to spend a minute with each of this. This is your ASHA worker. This is a bottom-up approach. What do you need in this? The ASHA worker is just asking questions from the population. आपके घर में किसी को blood pressure है, diabetes है, heart disease. So she is just asking just risk factors. 10 of these I will come to them. Then she refers to a high risk individuals to the PHC. In PHC, you identify waist-hip ratio, whatever you would like to do, and NAFLD suspects. Then you refer them for liver fibrosis. Management of uncomplicated is done there. Then they go to CHC. Please see, it is 100,000 population where you diagnose and risk stratify. Isko blood pressure, diabetes plus liver. And then district level hospitals are there. Now if you do this, let's say at the PHC level, 30,000 population, above 30 years, I have not taken above 18 because that becomes huge, it's about 10,000 people. इसमें से B and C निकाल दिया. Then ultimately you will see that you have 714 those who might have a problem. NAFLD load at CHC level 100,000 is about 357. But this is not every day. This is the total burden. No panic. You can do it in 1 year. Then the NASH cases which go to a district hospital about 100, cirrhosis 20, liver cancers 2. Now if we just manage this scenario, maybe 1200 people just need to handle 1200, but while doing 1200 we will find out so many diabetics, blood pressure, heart disease. So you are going to find with this method, bottom-up approach, an early screening diagnostic approach, and this is what we are pushing. And I would like you, anyone you meet, you can just communicate this. We need to have whole of society approach. The next thing, amongst ourselves, what can we do? Change our attitude. Believe me, change your attitude. I have seen children, when I was at GB Pant, every patient who used to go for angiography, the family would come, 3-year-old Muslim child, 5-year-old child, and I would do an ultrasound, 7 in the morning. They have grown up. Many have come with gallstones, many have come with liver disease in last 20-25 years. So please change your attitude, and from so what approach, liver fat is a fire alarm. I showed you the data. So how do you make whole of society? Every tailor has to be taught that don't fit jeans onto the guy. Ask him to fit into the jeans. And what is that fit into the jeans? Waist. When you go for a haircut, teach your barber, please do that. Teach your barber, anybody who has these warts or these black lines, भैया तू जाके डॉक्टर को दिखा ले. If you teach all barbers, every male person is covered unless he has some other better ways of handling. If he doesn't have hair, I can't help it, but otherwise you will cover the whole of population. Do you agree with this? All barbers. And teach your friends to tell the barbers. Because of this reason, the MAFLD term came. MAFLD is a new term. Everyone will simply understand. I'm not going into debates what you and others have been doing. But karna kya hai? All diabetics, 50 out of 100 have fatty liver. Maybe, in my opinion, 60-70%. Overweight or obese, 100%. 95% have fatty liver. So who has fatty liver? Obese, diabetic. So this is what it is. Now comes the lean, less than BMI 23. So the new term is metabolic dysfunction associated fatty liver disease is for everyone, whole of society approach. This is a beautiful article published in Hepatology Communications in NAFLD in a primary care setting in US. Now these are number of people. they have gone to a diabetic clinic or a primary health care. So these are 10 people. Out of 10, 30%. So NAFL is in 30%, NASH is in about 10 to 12%, and NASH with advanced fibrosis maybe about 5 to 10%. Or they go to diabetic clinic. Out of 6 people, you will see 3 have affliction. So diabetics, 3 even in US. So you have a navigator, you will screen them, FIB4 less than 1.3, low risk, FIB4 more than 1.3, and then vibration control your transient elastography if it is above 8. And then you refer them to a liver clinic. It's very simple, can be easily done. This is what we use at ILBS. Above 8 or 8 kilopascals, we think it may be stage 2 fibrosis. He may go for a liver biopsy. If it is less, he goes into a weight reduction and other programs. And this is what Arun published beautifully. I don't know if he's around, but this was a beautiful paper, and this confirms the need for a NAFLD diagnosis. Agile 4 score is your transient elastography, platelet, AST, ALT, diabetes, sex and age. And in this, age is not there. Now, all the NITs, non-invasive tests, are for excluding. This is to exclude that you don't have liver disease. But this is not confirming FIB4 of 1.3, then you do go for biopsy. The Agile score is the score by which it is inclusive. You are diagnosed, and the diagnostic accuracy, not exclusion, is about 90%. I'll not go into details, but use Agile 3 and Agile 4. Now, what does it mean? It means diabetes and liver disease is same. So NAFLD actually is a very simple primary care diagnosis. You have a diabetic, obese or metabolic syndrome, primary care physician or even nurses, community-based providers, a mobile van and a small lab. You may not even need a lab. And you can have a whole of society approach. Based on this, 2 years ago or more, we had the first guideline of NAFLD in the world. And there is a hot debate. The Westerners don't like, the Europeans don't like, but well, if people like, if it makes sense, maybe it will be worth. So what is the difference between NAFLD and MAFLD? MAFLD or NAFLD? 5 P's must be satisfied. Patient, can you identify? Yes, भाई ये overweight है, ये diabetic है, fatty liver है, screen कर दो. Physicians, a common physician understands at primary, secondary, tertiary level. Pharma understands भाई diabetes वाला इधर भी जाए, hepatology या gastro के पास या diabetics. Drugs are same, teach both of them. The pharma will teach both groups. Develop drugs together. Policy makers, so easy to make them understand. And public, I guess time will tell us. So what are the interventions? What you do for CKD? What you do for hypertension? भाई cholesterol कम करना है, ये खाना कम खाना है. They are same. So NAFLD or NPCDCS, the interventions are same. There is no difference. So my carry home and task for all of us is, if you want to reduce in India in next 1 decade, then join hands to reduce diabetes, non-communicable diseases, prevent, treat, screen NAFLD right now. Thank you all for your kind attention.